Welcome to this revision lecture on how to read the ECG. My name is John Boland. In this lecture, we'll try to revise all the previous lectures we've had on the ECG, which is far too big a task for one lecture, so we will concentrate on a few aspects of it. In interpreting the ECG, we must always remember to examine rate, axis, conduction and block, hypertrophy, ischemia, infarction, and of course, rhythm. Not necessarily in this specific order. Always look at the ECG as a whole and then focus on individual aspects of it until you have your interpretation. In evaluating conduction, it always helps to have a look at the P wave and its relationship with QRS. Is there a P wave before every QRS? What is the length of the interval? Is it within 0.2 of a second? Is there a QRS after every P wave? What is the length of the QRS interval? Remember, it's supposed to be less than 0.12 seconds. Are the P waves regular and identical? Are the QRSs regular and identical? And of course, the rate. Is it bradycardia or tachycardia? And it helps to determine the source of pacing. Is it the SA node, the AV node, or an ectopic? Always assess the intervals, the PP interval, PR interval, QRS interval, and the QT interval. And you know that the QT interval varies with heart rate, sex, and there is a correction formula, the Bazet formula, shown here, where the QT corrected equals the QT interval divided by the square root of the RR interval. And it falls within a normal range, which is taken to be normally as 0.38 to 0.42, but there is leeway in that. Remember, a segment is simply a section of the ECG baseline, whereas an interval usually contains a wave. The last part that we look at in evaluating the ECG is usually the ST segment. Is it elevated or not? Is it showing ischemia or infarction? We look at the T wave to see whether it's elevated or not, or inverted. And as we just saw, we look at the QT interval in terms of determining potentially lethal arrhythmias, which are often associated with congenital defects. Be aware of all these different measurements we must take and observations we must make, and the evaluation of the ECG should become fairly well automatic. Whoops. This brings us to the Q wave. We must establish whether there are any pathological Q waves, meaning as opposed to insignificant Q waves. To be significant, a Q wave has to be deeper than 2 small squares and or wider than 1 small square. And these types of Q waves are considered normal, are called septal Q waves, if they occur in leads 1, 2, AVL, V5, and V6, and some authors include as here, lead 3. And any bigger Q waves are considered pathological anywhere. Just be aware that there can be insignificant Q waves that do not mean pathology. And we'll follow that up on the next couple of slides. In terms of Q wave identification, let's have a look at lead 1. And this slide of Netter's shows very nicely what an insignificant Q wave means. Consider a normal conduction pattern for lead 1 on the left-hand side. Now, we've said before that the ventricular septum, the interventricular septum, depolarizes from left to right. And you can see here how the first initial deflection of the QRS complex moves away from the positive electrode at lead 1. This causes a little negative, or can cause a little negative blip on the QRS complex. Whereas on the right-hand side, with an infarction, which is electrically neutral or electrically silent, the main vector conduction is away from that positive electrode, so you get a much bigger Q wave here. And the position of the Q wave in relation to the lead tells us what part of the heart is being affected. In terms of differentials for a Q wave, there are only two. The Q wave can mean myocardial infarction, or an idiopathic hypertrophic subaortic stenosis, shown diagrammatically here as a thickened ventricle, as a thickened left ventricle. And you can see with a thickened left ventricle, the mean vector direction across the septum is downwards and to the patient's right, causing a much bigger Q wave than an insignificant septal Q wave, such that in IHSS, the septal Q wave in lead 1 is deep and prolonged because of excessive septal thickness. Other leads usually evidence marked left ventricular hypertrophy, such as V1 and V6 in this case. And you would look for the normal left ventricular pattern in your ECG if you have left ventricular hypertrophy. Start again. Interpreting the Q wave. There are many rules in interpreting Q waves, and they go back to a program, a computer program called the Minnesota Code that is far too complicated for daily use. Slides such as this are an attempt at summarizing that code for practical use. In simple terms, we always ignore lead AVR, and if a Q wave occurs in V1 alone or in lead 3 alone, ignore it. To be significant, a Q wave has to be more than 1 little square wide, or it has to be more than 1/3 the size of the R wave in its depth. A Q wave in lead 3 and AVF must be wider or deeper than in the anterior leads. Also, a Q wave in 2, 3 and AVF must be wider than 0.04 and has to have a depth at least 5 millimeters or greater than 1/3 of the corresponding R wave. Q waves are more definitive if paired with ST and T wave changes. A Q wave in a left bundle branch block is ignored, but not so with right bundle branch block. A Q wave with left ventricular hypertrophy, we must exclude the possibility of R waves first because it could indicate a posterior infarct. A small Q wave may be significant if V2 and V3 have large S waves, and poor R wave progression may indicate an infarct. Poor R wave progression meaning there is no increase in the height of the R wave as you progress from V1 to V6. And a significant Q wave can be indicative of either an acute myocardial infarction, as we saw in a previous slide, or idiopathic hypertrophic subaortic stenosis. And there you have to consider that it's due to left ventricular hypertrophy or a hypertrophied septum with septal forces of increasing magnitude take longer to traverse the septum, and that is often accompanied by a systolic murmur. Don't be put off by all these rules and regulations. As you become familiar with Q waves, you learn to recognize them and know what leads are important or not. But in terms of a revision, ignore them in V1 and 3 if alone. Remember, the basic rule is to be significant, a Q wave has to be greater than 0.04 wide and or greater than 1/3 the height of the R wave. So let's move on to ECG analysis. It's all very well to recap our rules and regulations, but to really become proficient with an ECG, it simply means analyzing. Look at as many as you can and try to understand their interpretation. We'll go through a bunch of them now. Let's have a look at this one. What do we have here? Always go through your basics first. Have a good look at the whole ECG. Is there anything that stands out? Is there anything abnormal? Then have a look at your basics. And by basics, I mean axis, hypertrophy, P waves, and so on. So let's have a look. P waves, regular, repetitive, paired with QRS complexes, so we're in sinus rhythm. Axis, leads 1 and 2 are positive, so axis is normal. In terms of conduction defects, let's look for block. There is that RSR pattern in V1 and V2. That's indicative of a right bundle branch block. Here they're being conservative and saying it suggests a right ventricular conduction delay. It all depends on whether it's greater than 3 little squares wide. And we always look for Q waves or ST changes. Now, in terms of P waves, this could be associated with hyperkalemia, potassium tent, remember, an excess of potassium ions? And are there any Q waves? There are none in the limb leads that I can see. That would be an insignificant one on its own, AVL. But leads V1 and V2 both have what appear to be small Q waves, but they're greater than one little square wide, and they're more than 1/3 of the R wave. Not so much this one, but they are in adjacent leads. So this is saying it's a septal infarct, age undetermined. That's because the computer has its built-in calipers and has established that these are significant Q waves. However, notice that because of that T wave, we look at the ST segments, and it looks like the ST segments in V1 and V2, not so much V3, are elevated. So V4 is also possibly elevated. So consider the possibility of an acute infarct, and I believe this patient is having an acute episode. Very subtle. There will not always be rip-roaring, but those ST changes cannot be ignored. Just be aware to look for the subtle differences, every bit as important as the big noticeable differences. Let's move on a little quicker if we can see what's going on here. Again, let's look at our usual observations and see what we can find. Well, immediately we can see this left axis deviation. Let's have a look at the P waves. They're a little tricky. There's something going on with the P waves. Now notice, this is leads 1, 2, and 3, and instead of this being lead 2, it is V1. So the P waves are biphasic or diphasic in V1. Let's focus on lead 2 where they're normal. So we're in sinus rhythm. Lead 3, they're a little diphasic there, but I'm not convinced there is any atrial hypertrophy. Let's have a look at the rest of the ECG. There is no block that is obvious. There's a partial, possibly an incomplete block, but it's nothing you would call greater than 3 little squares. And Q waves. Now there's a little R wave there, so that's not a Q wave. Again, let's have a look at these. Now these look like definite Q waves to me. They're more than one little square wide, and they're certainly bigger than the 1/3 of the QRS complex. They dominate the QRS complex, and they're in the septal territory. So let's look at the writing here. Pretty well agrees with what we said, sinus rhythm. I missed that first degree AV block. Yes, I meant to go back to it. My calipers would have picked it up. And this was fortunate that they had a previous ECG to compare it with, and there was no significant difference. So immediately there is no action taken, other than to recognize his pre-existing history, which is also important. Most of the time you will have the patient's history in evaluating these ECGs. Here, we're looking for individual isolated signs just to familiarize you with identifying specific features. So if a patient comes with rip-roaring chest pain and you have only subtle ST elevation, you know it has to be real. But for the moment, let's continue just with individual observations. This is a nice cleaner trace. We haven't been looking at rates so much because you are obviously familiar with how to calculate your rates, but it should be part of your normal examination. Left axis deviation, one of the first things that stands out, and you have some kind of a conduction defect, and it looks very much like your standard left bundle branch block pattern. Deep S waves in lead 1 and little rabbit ears or widened QRS complexes in lead V6, possibly even V5. So that's the left bundle branch block. You have normal regular P waves. There's a temptation to call it first degree block, but I doubt that you would do it unless your calibers tell you so. And the PR interval here is 185, so it's unlikely. And it's simply sinus rhythm with left bundle branch block. Now, this one, we've seen left bundle branch block, and the thing that stands out here is an RSR pattern, more so in lead 2, but it's evident in lead 1. But let's go through our motions for everything else again. Q waves, insignificant isolated Q waves in lead 3, so we ignore that. V1, tiny insignificant little Q waves, no evidence of hypertrophy, no other signs that jump out at you. The P wave is present and regular and paired with a QRS complex. So that would be a right bundle branch block in normal sinus rhythm. The writing is a bit vague, but we can see it. It says you cannot rule out an inferior infarct, age undetermined. It's going for this Q wave in lead 3, which I would disagree with. That I would call an insignificant Q wave because it occurs only in lead 3, and lead AVF is totally insignificant. Again, these analyses by the computer are pretty good, but they're not foolproof and you don't have to always agree with it. But that is a reflection of experience and confidence. Let's look at this ECG. What do we find here? Well, first, remember we should always exclude in every ECG certain considerations such as atrial fibrillation, atrial flutter, is it in tachycardia of some sort, is it a VT, is it an SVT? And whenever I look at these, of course, they're the sort of things that are at the back of my mind I always look for or exclude. And here, because I'm looking for atrial fibrillation in every one, I immediately pick this up. There are irregular beats with no discernible P waves paired with a QRS complex. Atrial fibrillation with a slow AF. And not to be distracted by that, you can't tell without your calipers, but there's a little slightly wide RSR pattern here, and it's diagnosed as an incomplete right bundle branch block. Happy with that. Now this one is an interesting one. Just because you find Q waves in one site or ST changes in another site doesn't mean that there's only going to be one infarct. And this one is interesting because in bold print there, you're in bradycardia. Let's accept that it's in sinus rhythm, but there are two potential infarct sites. Now the one that jumps out at us most noticeably is leads 2, 3, and AVF, which we've seen before paired quite regularly. But notice in the lateral leads, V4 to V6, there is ST elevation and is not reciprocal to that. It's not ST depression, is ST elevation. So this person is having two occluded vessels at the same time, and that is not uncommon. So always look for these sort of patterns in more than one place. Similarly with this slide, it's not particularly good in terms of establishing a baseline, but looking at it closely, again, we establish that it's in sinus rhythm, but what jumps out is the ST elevation in the inferior leads. 1, 2, 3, and I presume this is lead 2, a little hard to read, but if you look at leads 2 and 3 and AVF, again, they all show ST elevation. And look at this. As in the previous slide, except instead of being restricted to just the V5 and V6 leads, in leads V2 right through to V6, there is ST elevation. Two potential infarct sites that look very real to me. Sinus rhythm, anterolateral infarct, acute, borderline ST elevation infarct leads. Well, it might seem borderline to the computer, but I would find those pretty convincing. It's probably that lead 3 is a little flatter. Remember the rules for determining all this can be specific, and unless you get your calipers out and measure them, which would be impossible without a grid, you might be just within the borderline there, but I would be happy calling this probable inferior infarct. And that word probable or possible or likely are very useful. Let's look at this one. Let's accept that it is tachycardic. I think that's the first thing that stands out. In terms of axis, we wouldn't worry about that too much. There are P waves and they're regular and they're paired. I think mostly, yes, every now and then there's a possibility of a slightly different RR distance, but your calipers would confirm that. And what else stands out? These ST elevations. Look at V5, beginning with V4, V6, but also in V2 and V3, all your septolateral, all your anteroceptal leads. Consider an acute infarct. Well picked. In all of these, of course, you should always look at your QT intervals. We haven't been doing that, but there's always a possibility that you would have long QT syndrome. Coming on to the next slide. Now, this is not that abnormal looking. What have we here? Sinus rhythm, although barely perceptible, but you measure them and you find they're regular. This one is a little shorter. That's probably an atrial ectopic. And normal axis. Any Q waves? Hypertrophy. I thought of hypertrophy because of the height of these R waves, which is what stands out, and that is the giveaway in this case. You would find the R wave in V5 plus the S wave in V1 is greater than 35. There are other criteria to go by, of course, such as your strain pattern, consistent with left ventricular hypertrophy here, and in some instances, R wave in lead 1 and the S wave in lead 3 should amount to more than 25 millimeters, and that's one of the other criteria that we need to be aware of. Left ventricular hypertrophy, a nice little example. In this one, I've deliberately left the labels so that when you revise this, you're not confused by what might be there, although always remember they may not be entirely correct. What stands out here? Regular P waves, regular rhythm, no axis deviation, any Q waves, possibly an insignificant little Q wave in lead 3, like I said, as in V1 you ignore, although look at this is a potential Q wave, but it's only in lead 1 and it's isolated. And it's most likely associated not with a true Q wave and existing infarct, but some of the S wave in V1 and the R wave in V5 is definitely here more than 35. So you have left ventricular hypertrophy, and what they call a repolarization abnormality is what we keep referring to as the strain pattern. But the correct terminology, of course, is repolarization abnormality. Let's have a very quick look at some revision slides. It's probably not necessary for you at this stage, but as this is a revision lecture, even though we're pushing for time, let's move on. Remember to analyze your P waves for atrial hypertrophy. You know about the P pulmonale. A tall P wave more than 2.5 millimeters is called P pulmonale, and it's associated with right atrial enlargement or hypertrophy. P mitrale, left atrial enlargement or hypertrophy, and it is generally a bifid wave indicating mitral disease, hence the name P mitrale. The PR interval, remember, if it's short, it can signify an accessory pathway between the atria and the ventricles. And one example of this is Wolff-Parkinson-White. I haven't shown you any real examples because we don't come across them very much. They're certainly EP territory, but this next slide will revise it. It's worth going through it again. What we look for is this delta wave, this slurring of the upstroke of the QRS complex, and you can see it has a long intrinsicoid period. Depolarization, as is often the case, begins in the SA node. The wave of depolarization spreads through the atria. One pathway leads to the normal His bundle, where it undergoes a 1/10 of a second pause. But with Wolff-Parkinson-White, there can be an accessory pathway or more, and conduction proceeds without that 1/10 of a second pause along the ventricular walls. The accessory bundle has no delay, and so ventricular depolarization begins early until such time as the normal conduction down the His bundle catches up with it. So that delta wave represents that early depolarization from the abnormal conduction pathway, the accessory pathway, and Normal QRS complex depolarization follows, giving you that typical appearance for WPW. Again, at the back of your mind, you should always be looking for these little delta waves, as you would with AF, atrial flutter, and so on, the other little bits I've mentioned. QRS height. Remember to look at the QRS height, as we've seen in a couple of examples for left ventricular hypertrophy, S wave in V1 added to the R wave in V6. Has to be more than 35 millimeters mercury. The QRS width, of course, indicates block, bundle branch block in particular, if it's more than 0.12 of seconds. Some books say less, but I think that is the recommended guideline. So we then have to determine whether it's a left or a right bundle branch block. We've seen two examples in this lecture. In terms of axis deviation, use your fingers. It'll simplify your life considerably. Right axis deviation with your right hand, fingers together. Left axis deviation with your left hand, fingers apart, representing leads 1 and AVF. Very simple, straightforward. Remember, if leads 1 and 2 are both positive, you have a normal axis. Left and right bundle branch block. We've seen examples here. The RSR pattern in V1 indicates right bundle branch block. That deep S wave with rapid ears in V6, left bundle branch block. We'll come finally to localizing ischemia, and I hope you remember this diagram showing you how we have lateral leads, 1, 2, and AVL, how we have frontal leads, V1 to V4, indicating the anterior aspect of a heart, and 2, 3, and AVF look at the inferior wall of the heart. The anterior aspect is supplied by the left anterior descending coronary artery. The lateral is usually supplied by the left circumflex, unless the right coronary overtakes some part of that territory. And the inferior wall is usually supplied by the right coronary, but it can also be supplied by the left circumflex if dominant. There are other ways of remembering that. You can visualize the vessels in your mind. The inferior wall of the heart is supplied by the right coronary artery and is read by leads 2, 3, and AVF. The lateral part of the heart is supplied by the left circumflex usually, and that part of the heart is read by leads 1, AVL, V5, and V6, and lead 2. And the anterior septal part of the heart is read by leads V1 to V4, and that is supplied by the left anterior descending part of the heart. The most important and biggest supply of the heart to the heart is from the LAD. Another way of looking at this anatomical representation is to look at this little box. Get leads 2, 3, and AVF out of the way, and they're gone. Then your lateral leads, 1 AVL, V5, and V6, and V1 to V4 are your septal and anterior leads. And here, V1 and V2 are looking at septal portions, but in some diagrams, it's V3 and V4 that sit over the septum. So this can be a little confusing. Just remember, V1 to V4 is anterior septal territory. Finally, we come to posterior infarction. And we'll start here with the bottom left. Remember that ST elevation and Q waves in V1 and V2 represent an anterior infarct. I think that should be pretty clear in your minds. But the opposite of that, ST depression and large R waves in leads V1 and V2, as here, represent posterior infarction, acute posterior infarction. So ST elevation in V1 and V2 would indicate anterior infarction. ST depression with prominent R waves in V1 and V2 indicate the opposite aspect of the heart, posterior infarction. And you can see here how the posterior wall of the heart is facing the opposite wall of the anterior part of the heart, which is read by leads V1 and V2, but there is no posterior leads, so we look at the mirror image of leads V1 and V2 to detect a posterior infarction, and the mirror image indicates ST depression. And finally, a summary of the different areas of the heart that are affected by infarction. Lateral, Q waves in lead 1 and AVL if you suffer an infarct. Anterior, V1, V2, V3, or V4, anterior septal. Q waves in those leads indicate infarction. Inferior, our favorite 2, 3 and AVF, Q waves in those leads indicate an inferior infarction. And remember the posterior, the opposite side of the wall of the heart from the anterior, large R wave in V1 and V2 with ST depression. And here it says maybe a Q wave in V6. We've gone way over time, so I might end that there. I hope you've appreciated the complexity of ECGs, and I hope this lecture just summarizes a few extra bits and pieces for you for your exams. We've come a long way in these few weeks that we've studied the ECG, and you should be quite pleased at the level of understanding that we have all reached, and that you continue to read and study the ECG. That's the only way you will remember it long term. And with that, I will end this lecture, and good luck.